So amidst our instruction course, we have a guest speaker to have a keynote address, our past president, Dr. QURESH MASKATI sir. I invite him upon the stage to deliver his talk on quality of life in dry eye patients.
Thank you, Manoj. And I feel like a goods train engine, which has been, because it was a keynote address, and the scientific committee then just found an available hall to latch the goods train engine to. So it's not necessarily something directly connected with this session. I apologize. Just one comment on what Manoj said in the beginning about what are the things that can go wrong and make an unhappy patient. Sometimes there are patients who are unhappy because they choose to be unhappy. So it's not your fault, it's not instrument error, it's just that the patient has chosen to be unhappy. I did a black cataract patient who came to me in the pre-op. In the chatting, he was talking about whether he should adopt a child or not adopt a child, means completely extraneous issues that should have triggered a warning that this man is cuckoo. But so I did the black cataract to the best that I could and gave him 6/9 vision. And then in my 35, 40 years of practice, I'd never been sued. This was the first time I got a legal notice, because he told me that when he drives at higher than normal speeds on the Mumbai-Pune expressway, which is at 120 to 140 kilometers per hour, at that time the legal limit was 80. Then he sees halos around the lights. I had put a monofocal. So he's seeing halos around the lights. I said, what happens if you drive at 80 kilometers per hour? He says, then I don't see them. So for that complaint of his, I got a legal notice. So sometimes it is the patient who is unhappy, who chooses to be unhappy, nothing that you have done. So don't always blame yourself or errors in biometry or instrumentation. Just this, so I had to say something on the topic of the day, and then to go completely off tangent now. I'm talking on quality of life issues in dry eye patients. I've been talking on dry eye since about 20-30 years. People have stopped wanting to listen to me. So I came out with something else, which is dry eye, but why we should continue to talk on dry eye nowadays, because we have something called QOL, or quality of life issues. This is not used only in ophthalmology, it is used in every part of the body. In angina, what is the patient's quality of life? In somebody who's got pneumonia, what is his quality of life? Heart attack, what is quality of life? And so on. Depression. So we look at dry eye not only from which drop to use when, but from a holistic point of view. How does dry eye affect the psychological, the economic impact of dry eye? And we did a little review article, and it got published in a journal. So emboldened by the fact that if a journal could accept it, perhaps Opal Hall could also accept it. This is why I'm here today. So we know the prevalence of dry eye is huge and getting worse. In COVID times, it became worse in children and adolescents, and kids who are on with digital eye strain because of e-schooling. Almost everybody got some amount of dry eye. All our computer programmers get some amount of dry eye. Tejas, you're taking my picture or the audience? I don't know whether to pose or not to pose. So challenges with photography, challenges with dry eye diagnosis. Definition of dry eye is still debatable. We had huge numbers of expensive workshops called the DEWS Workshop 1. Came out with one definition, and then the DEWS Workshop 2 in 2017 came out with another definition. They're gathering funds to have a DEWS 3 so that they'll have one more. There is also an Asian Corneal Society which has a different definition. So there is not only definitions, the absence of gold standards for diagnosis. It's not you take intraocular pressure in the patient's glaucoma because he's 40 pressure. So we don't have a gold standard. We have poor standardization amongst the diagnostic tests which are there, whether to use Shermer's 1, Shermer's 2, whether above 15, below 10, what should be done. Then we found out that corneal nerves have some role to play, and that causes more symptoms than signs sometimes. And sometimes you find if you are a careful examiner, then you get more signs than the patient has symptoms. And some of the what you might call gold standard tests are extremely expensive. You can't do osmolarity tests unless you're in an institution setting. So you have huge problems with this. But the impact of dry eye is comparable. So if you look at this slide, Moderate dry eye. Now, imagine that 100 is the highest you can have, and 0 is no impact on quality of life. So, a mild dry eye, a moderate dry eye is almost equivalent to, if you see severe angina or a hip fracture, they're almost at par. So, mild and moderate dry eye is almost at par with somebody who's got a hip fracture or an angina or a heart attack. So, it's that much of an impact. We always feel that dry eye patients are a nuisance to us, and we wish they would go away, and we give them 2-3 bottles from our second drawer on the left, because that is where you keep your dry eye medicines. But the patient goes away, but the impact on his life is such that he will visit 5 or 6 different doctors until somebody finally puts a hand on his shoulder. So patients with dry eye were 2 or 3 times more likely to report difficulties in daily living activities than those without dry eye. And this is normal activities that everyone will do. It's not some abnormal thing that is doing driving at express speeds on express highways. So there is a humanistic burden. Daily activities are impacted. The quality of sleep goes down. Again, something not commonly understood. Last 2 or 3 years, I've been asking every dry eye patient, especially females between the age of 40 and 60, whether they sleep well at night. And it's amazing that almost 80% of my patients say, no, they don't sleep well at night. And it's a vicious cycle, because of dry eye, they don't sleep well. When they don't sleep well, the dry eye gets aggravated. And they don't want to participate in activities which are there because they're so troubled by their dry eye. So even leisure activities, recreational activities, they become introverts, they become withdrawn, they become depressed, all because of dry eye. Something which we don't look at the overall picture. So again, sleep disorders are very, very common. So check with them. Sleep deprivation, poor quality of sleep, sleeping during the day, sleeping at work or in school. Even kids sleeping in school, the teacher sends a remark back, the parents slap the child. But the issue is the dry eye. And look at the percentages. 40 to 45%, more than that in my series, but mine is a non-randomized, non-controlled, very biased study. So depressive symptoms I was telling you about, very, very real. If you ask them whether they get anxiety, it starts with anxiety symptoms and then goes on into full-blown depression with these. So as I said, ask these questions and you will know how badly the dry eye is impacting them. So all they need, along with the drops, is some amount of empathy to be shown. And why must we treat? Forget the patient itself, but it's a huge economic burden on the country as a whole. We don't have data from India, so I looked at some data from abroad, and they could quantify. Everything is quantified in the millions, billions, and trillions of dollars, and it's a huge economic burden to the person employing a dry eye patient, as well as to the patient himself, because he misses so much of work time. So economic burden, loss of work productivity, mild 91 days, moderate 94 days, severe almost half the calendar is lost because of this. Therefore higher economic costs, and somehow they came out with this 3.84 billion. Even if you don't believe this, it's on the lower side according to me. It will be more, even in our country it will be there. So dry eye patients, significantly, whether they're working from home or they're working from the office, it really makes no difference, because the computer is common to both the places. So the productivity goes down. Even at home, they're not working as efficiently as they should. Absenteeism increases. So in conclusion, during the COVID pandemic, studies on quarantine dry eye were reported across the world. Prevalence of dry eye is likely to increase now because the digital devices have become more common. Digital schooling, almost every school or every school that could afford it would tell the patient, tell the kids, don't come to school, but we'll give you work on the screen. And most didn't have laptops, so they all worked on small little mobiles. We know that the smaller the device, the worse it is for dry eye. India is an emerging economy with a growing middle class, increasing urbanization, increasing use of the internet. We are growing much faster than any other country as far as internet connectivity is concerned. So this does call for an urgent relook at dry eye, and not only from the eye drop point of view, but again, as I say, we do need more Indian studies on dry eye. We have a paucity of Indian data. and therefore we are not sure. We are using Western questionnaires like the DEQ5 and the OSDI. We are not sure whether we should be simplifying it and using some simpler questionnaires which will bring out the impact of dry eye on the Indian environment. So it's a call to action for all of us, that we need to understand a full medical history. Besides asking about medications which we do, maybe we should ask them also about sleep patterns, about eating patterns, about anxiety, about depression, perform objective tests, ask probing questions, better questionnaires we need, and more effective management to treat the patient as a whole rather than just the dry eye, and do consider some alternative and supplementary treatments as per the DUES classification. Thank you so much for your attention, and apologies for impinging on you.